And we are live.
All right. Hi, everybody. Thank you so much for staying on and listening to our live Q&A for Theme 2, Economics of Disease Control and Considerations for Public Health. I think you'll all agree that we had three great presentations from Dr. Kai, Dr. James Trower, and Dr. Irfan Ibrahim. All of them are actually live with us at the moment, and we look forward to having a pretty lively questions and answers and speaking to them. Maybe I'll begin by asking an open-ended question, which has actually been trending in the live blogs. What are some of the lessons learned from previous pandemics, such as SARS, in terms of modeling scenarios? So anyone would like to take that one on?
I'm happy to. If I can get started with that if you like. I'm James Trower.
Please go ahead,
Monash University. I mean, I think there were a lot of mistakes made, really. I mean, when you look back at SARS in 2003, the fact that we didn't have a coronavirus ready to go at population scale is pretty incredible. For whatever reason, we didn't put in place the market incentives to develop that vaccine, and I think, like, SARS should have been the the thing that alerted us to the fact that a coronavirus pandemic was possible. I mean, we got really lucky with SARS. It could well have been a pandemic, and the fact that we did not develop a vaccine at that time is, I mean, in retrospect, it's pretty staggering. Coronavirus vaccines are very, very difficult to develop, and I believe from my colleagues in veterinary science and sort of the One Health movement that coronavirus vaccines have been sort of under investigation for a number of decades, and yet there's never been an effective animal coronavirus vaccine. And now we've sort of been faced with a scramble for a human coronavirus vaccine, and we're certainly making some good progress, and yet at the same time there's some concerns around the quality of the trials that are being put together to produce these coronavirus vaccines. But I mean, I think that's one of the biggest things for me. We did not learn a lesson from SARS.
Absolutely. Thank you, Dr. Trower, for that answer. We have also some very key specific questions regarding your presentation specifically, James. There was actually, you had some very nice data around fatality rates, infection fatality rates. And one of the things that was quite striking was the excess death rate, if you recall. Can you speak a little bit about that, about how excess death rates in different cities compared to usual death rates correlates with how modeling accuracy can be calculated?
Yeah, I'm happy to make some comments on that, and I think it's something that was very much part of Irfan Ibrahim's talk as well, so perhaps he might like to follow on after I've made a couple of comments. But I think there's no question we've seen big spikes in all-cause mortality in many countries around the world, and that is largely attributable to the direct effects of COVID, although there are some other effects that are relevant as well, in that the coronavirus mortality, I mean, as Irfan Ibrahim pointed out, sometimes the mortality, attributing it to coronavirus, is somewhat difficult, and there are deaths that probably are attributable to it that don't get appropriately attributed in that way, and some that are attributed to it but are not actually a result of it. So that, again, there's all the usual sort of data issues around estimating exactly what effect there's been. And so I think that means that looking at all-cause mortality is a really important way of gauging the impact of the pandemic. If you just look at coronavirus attributable deaths, then you don't get the full picture. The all-cause mortality is a really important thing to look at in addition to that, although there are these sort of issues around it, and there are also non-COVID related impacts of the pandemic. Clearly, the lockdowns themselves are changing the patterns of mortality. So the lockdowns mean that we have fewer deaths related to motor vehicle accidents, for example, and more deaths related to suicides, presumably, that sort of thing. So we see different patterns, and the net effect is, again, sort of difficult to really tease out. But I think one of the most important things people don't talk about is the fact that coronavirus deaths are very strongly distributed towards people who have very high all-cause mortality. So as much as we see these spikes in all-cause mortality, we might see some catch-ups later, and there's a phenomenon sometimes referred to as harvesting, where deaths are sort of brought forward, but they're deaths that might have occurred within the next 6 months anyway. So the people who are within the last year or two of their lives are very much overrepresented in the coronavirus mortality. So it is possible that we're going to actually see some sort of compensatory falls in all-cause mortality over the coming year or two, post these sort of initial waves of coronavirus.
Thank you, Dr. Trowell. So please go ahead, Dr. Abraham. Would you like to elaborate further on that?
James made several points that I agree with. I would like to just add that the flu season plays havoc with these numbers. When I look at it globally, we find that on the low end, the flu season can have as low as 290,000 deaths across the world, and then as high as 610,000 deaths. If you look at the current casualty from all of coronavirus, it crossed 690,000 a few weeks ago. So when you look at the United States, for instance, you could have as low as 12,000 deaths by flu and as many as 60,000 deaths. So when you combine that with the coronavirus deaths, there can be a lot of anomalies that are created. And then the point that James made about the comorbidities, that when you have cardiovascular problem or diabetes or other comorbidities, there are a lot of people who have died who fall in that category. And then when you combine that with older age. So while there was a surge in deaths in that March to June timeframe and continues, but there are many factors that add up to that kind of statistic. So we can't make a one-to-one correlation like that.
Great. Thank you, Dr. Abraham. Now, moving on to Dr. Kai. You had a very good presentation, Dr. Kai, and we had a lot of response and a lot of questions drawn on your presentation. One of the things that you referred to at the start of the presentation was the 6.6% healthcare expenditure that China has spent, I think, in 2018, I think the last data you had. So with respect to moving forward, because you did have a lot of emphasis on the fact that there may be more awareness of public health issues in China, how much more do you think healthcare expenditure will increase by in China? And is there some starting policies, government policies for allocation of that healthcare expenditure in China?
Yes. Look at the trend in China last few years. We see the healthcare sector to annual increase, it's double-digit increase. However, the GDP increase right now is gradually declining. So we expect the healthcare expenditure among the GDP share should increase fairly rapidly, reach to like 8% or even 9% within maybe 5 to 10 years. So should be compared, look at the history. In the last 80 years, China GDP share has increased from 3% to right now 6.6%. So that's will be changing in the future, considering combining the both GDP increase rate, combining the healthcare expenditure increase rate.
Thank you, Dr. Kai. And a follow-up on that, you had some very nice data around online versus offline consultation in healthcare. Do you think that will advantage the tier 1, 2, or 3 hospitals in China? Do you think that has a bias towards big cities, or you don't think that has an advantage or bias towards big cities, the online consultation?
The online consultation tend to be between the tier 3 hospital within the big cities like Shanghai, Beijing, Guangzhou, linked to the remote area. So that's will be because the experts will be very highly concentrated in the big hospital in the big cities. For the remote area, they really lack of the qualified professionals. So the online consulting really helped to try to bring these kind of gaps, reduce these kind of gaps. Mm-hmm.
Yes, fantastic. Mm-hmm. Also, I think just an open-ended question to everybody. I think the $1 million question now moving forward, and I think some of this was addressed a little bit by our keynote speaker today, is the level of immunization that a population needs in order to reach herd immunity. Any thoughts on that from any of our speakers around that? Because I think that really ties into the when the vaccine is going to come out and who gets the doses. So just an open-ended question if anyone would like to answer that from the Q&A.
Yeah, I would like to.
Oh, yeah, go ahead.
James, go
ahead. Please
go
go ahead, Dr. Abraham.
Okay, thank you. So I think we first have to get a good handle on the reproductive ratio of a disease before we start figuring out at what level herd immunity is going to occur. And I think that the jury is still out on what the actual reproductive ratio of this disease is. I think initially they were thinking it was lower until they found the asymptomatic cases, and now they can't quite say where that value is, and herd immunity is a strong function of that reproductive ratio. Go ahead, James.
Sorry, yes, I totally agree with those comments. I mean, yeah, and there's been a few trends towards changes in estimation of the reproduction number or ratio, including that early in the epidemic we took estimates of the serial interval from SARS, which is the interval in between one person being infected and the person whom they infect being infected. And so that turns out to be shorter than what we had thought. So that has also led to some changes in what we estimate the reproduction number to be. And there's a formula that can be used to derive the herd immunity threshold from the reproduction number. And that is pretty solid formula in the case of homogeneous mixing. If we just assume that everybody is equally likely to infect everybody else, and there's no heterogeneity in contact patterns, then we can calculate pretty quickly that from a reproduction number of 2.5, we're probably going to need about 60% of the population immune to get to herd immunity. And so that message, I think, is a message that is pretty prominent in the literature generally, and it's probably not too far from the mark. Heterogeneity is probably more likely to lower the threshold, the herd immunity threshold. So it may be that it's only necessary to have about 40% of the population immune to reach herd immunity in the presence of heterogeneity. If the most susceptible and the most people with the greatest risk of transmission are the people who also get infected, then that heterogeneity can lower the herd immunity threshold. So I think that's one factor that plays a role. But for me, actually, the biggest thing that we should keep in mind is the herd immunity is a threshold at which disease dies out. But just reducing the transmissibility or the sort of the infectiousness of the epidemic to some extent is going to be a huge benefit. For example, we're in stage 4 lockdown in Melbourne here, and I am allowed to go outside of my house after 8 p.m. So we've got pretty strong lockdown measures. And in order to avoid the situation of ever having to go through that again, you don't need to be anywhere near herd immunity. If you have sort of like, a 20% of the population immune through vaccination, for example, and then you down to an extent that you reduce your contacts by another 10 or 20%, you're going to have a pretty manageable, controllable epidemic. So I think we've got to bear in mind that even getting a sort of a small but substantial proportion of the population immune is going to make a big difference to how hard this thing is to control.
So,
wow, thank you. That sounds very promising. Over to you, Dr.
Farhad, I'd like to add something from a different discipline. Since I come from the cybersecurity area, Let me share with you, your audience, a metaphor or an analog to the analog virus we have called COVID-19 with a digital virus and how we protect. So while herd immunity is a good concept, but to get there, the number of deaths that would occur would be ridiculously high, no matter what the fatality ratio is, if the number is going up north of 40, 50% of the population. So my recommendation is that we need to look at this as a lifestyle virus. And as James mentioned, when you have that stage 4 lockdown, it contributes about 20% reduction. Combined with the vaccine, you're getting to a very effective level. But you could also think of it as creating clusters of people that spend time together, that know each other's history. And the equivalent of that in cybersecurity is called whitelisting. We whitelist applications to avoid the spread of viruses in critical systems. And so I would like to encourage the audience to look at that as a way of operating in clusters of people that have uniform behaviors whose history you know. And that way you can protect yourself from the larger community. Because today, family is still the number one way of spreading the virus, when unknowingly someone goes out, comes home, and infects everyone because they trust him. So we have to learn who to trust.
That's a very good comment, Arne. Actually, it's a very nice segue into my next question, Dr. Abraham, for you. That's come into the live blog. So given your background in mathematics and experience in IT, do you see a role in artificial intelligence and big data in getting more accuracy with the modeling scenarios that you presented in the future?
Absolutely. What we can do is use data analytics. First, we need to start learning how to segment the population into meaningful clusters, and then do the analysis on those clusters, and then combine it to create an aggregate model. And this is where artificial intelligence and data analytics comes in very handy. The other dimension where data analytics will come in is looking at the genetic makeup of the people who are surviving and who are unfortunately passing away, and looking for correlations for certain genetic markers. It's not enough to just look at age or just look at the diseases like cardiovascular or diabetes. We need to see why certain people, even at 102, survive after getting it, and others, are dying in their 40s and 50s. So I believe that if we go a little further into the genetic testing of people, and then looking at the patterns of those genetic markers relative to the statistics of survival and death, we're going to find some very interesting information.
Fantastic. And now over to Dr. John Kai. During your presentation, Dr. Kai, you referred to the medical qualification within the physicians in China, and there was a disproportion of the university qualifications versus high school. So do you think in the future, in terms of pandemic preparedness, what is happening in China in terms of bringing those qualifications more? Do you see any collaboration within universities and other medical institutes in terms of pandemic preparedness?
Thank you. They're good questions. In China, the mainly problem we have a really ironical dilemmas. On the one hand, we have a huge shortage of qualified doctor professional, but on the other hand, we see every year the medical school graduates, they just give up or go to the clinical practice. They change to work for example, for the pharmaceutical company, for the medical device to be the representative. So the bottom line problem is in China, the pricing for the medical service is still quite low. So the doctor professional, they couldn't get the reasonable compensation for the doctors. So they have to rely on the overusing the drug, overusing the material and the tests to compensate the loss on the service. But we see the policy change right now. The government social health insurance starts from the last few years. They start to reduce reduce overusing the drugs, reduce in the distribution channel of the pharmaceutical, because there are a lot of money stay there. They want to really reduce the drug price, reduce the material, test the price, to switch the money to compensate the doctor. But right now, still, this is ongoing things. We don't know how soon we could get the satisfactory results. But I believe still take some time to be finally the physician in China. It's like most of the country to be a very reputable, very competitive career for people, for talented people, for highly intelligent people to want to be a doctor. So far, not yet. Not yet. Mm-hmm.
Fantastic. Thank you for that answer. Just an open-ended question to our speakers. I think the other thing that's been really something that's been a lesson learned within this pandemic has been some countries have taken a different approach, whether they have had more pandemic preparedness, such as countries like Taiwan and Singapore from previous experiences, versus other countries where their medical systems and their hospitals has been really challenged. In your opinion, what are some of the lessons of the benefits of the hindsight? So in terms of pandemic preparedness for the future, what do you think the countries and governments should do in order to be more prepared for the future?
Let me take that.
Please go ahead.
United States, given the fact that we have more fatalities than any other country on the globe, and yet we are 5% of the world's population, it's frankly speaking embarrassing, where we are also the country that has made so many advances in medical sciences that help the whole world. But the lesson is very simple. We were asleep at the wheel for way too long. And when I say that, we wait until there is a 0.2 out of, I don't remember the exact number, but there's a certain percentage threshold for the population after which we start taking emergency action. We need to start a lot sooner than that. It shouldn't be based on fatality. It should be based on the infection spreading. By the time we started doing contact tracing here, it was too late. And then we just went into this lockdown mode, which wasn't really a lockdown because there was so much leakage through emergency services people, through the delivery people, and just people having to go to work, mostly in healthcare, that were continuing to spread the virus. So we have some real challenges about what we call T equals 0 in a pandemic, and that makes a big difference. If you look at the model countries that you just listed, Farhad, you're going to find that they started much sooner than we did.
Great. Thank you. Over to you, Dr. Trau. Any comments from your side in terms of pandemic preparedness for the future?
Well, yeah, I certainly agree with what Irfan just said. And I'm at risk of spilling over into personal opinion, I suppose, in responding to this question. But I just feel like one thing that has really illustrated this pandemic is how important public institutions are. And even if you are the most, I'm not, but if you are the most sort of economically neoliberal-minded person in the world, you would still probably want to have enough sort of government-based strength around public health systems to protect your markets from the effects of this pandemic. That's sort of a neoliberal way of phrasing it, I suppose, but I think it just more broadly has indicated how important these public health institutions are. I mean, for example, in Australia, we don't have any equivalent of the US CDC. So as much as the US has obviously had shortcomings in its response, Australia, we don't even have any sort of formal national mechanism for responding to public health infectious disease threats like this. So we're sort of, we're behind just about every other country in the world in that sense. So we're sort of, I guess we're lucky that some of our lockdown measures paid off, and I think that might be partly due to our small population and the fact that we achieved elimination in a lot of states, so that most of our individual states have sort of been around that elimination level and have had not too much trouble. But we were just, we were scrambling to put together a coherent public health response because of years of running down the public health institutions that are required to respond to something like this. And to me, that's the only response I can give. I'm sorry if I'm spilling into personal opinion.
No, that's fine. I think that's definitely true, and it's been a challenge for every country. Dr. John Kai, any comments from your side in terms of benefits of hindsight and how, for the future, China could be better prepared?
Yeah, in the future, China, I'm thinking the very important from the beginning of outbreak, the China system. Although we had after SARS, we already have the data reporting system, but how we should share the power, who should make the decisions, who should allow the transparency of data. So this is the things we need the really improvement. That's the lesson we had in the Wuhan in the beginning, because when you find some few data, some few spots, you need very quickly make the data available to the whole, directly to the system, who should the CDC, because in China don't have the power to make the announcement. So these kind of things we should straight out.
Fantastic, thank you. One last question has come through. I think we're kind of getting close to the end of the live Q&A. Dr. Abraham, one for you. You mentioned the 18 days from infection to death, which was one of the slides that you presented. One of the questions is, was this age-related or other disease complications corrected?
Yes. So now this is a very interesting thing, is that 18 days is not a function of age. That is actually based on a lot of their comorbidities, as well as the fact that if you look at the way a person typically dies from COVID, they develop these pneumonia-like symptoms. And it actually isn't real pneumonia, and not like in the bacterial sense of pneumonia, a traditional pneumonia. Yet, the way the disease and the way the body fights that disease, it creates a lot of residue, and that residue in the lungs creates this pneumonia-like symptom. So what this 18 days is an average of the time that someone succumbs to the symptoms of this disease. So it is as soon as 15 days and as late as 22. Some, I believe in Wuhan, one person died at 37 days after infection. So there are those outliers, and there are definitely people who die much sooner than that. But the weighted average was between 15 and 22 days. So I took the midpoint of that as 18.
Right, thank you for that. One more question that's come. I think it's an open question to everybody, so we may begin with Dr. John Kai. The question is, has the COVID-19 pandemic created new collaboration opportunities, whether within your country or internationally? So over to you, Dr. Kai. Any new collaborative opportunities?
Yes, we definitely need that cooperations. We do see that China, within the last 6 months, China started to really to try to give the information, give the data, give some resource shared among the international communities. Also within the China, in the China, definitely we have a lot of cooperation between the different community, between the different kind of provinces. Yeah, we do see definitely for the Wuhan in the beginning, the lack of the physicians. So it's pulling from everywhere in China for the thousands, the healthcare professional into the Hubei, into the Wuhan. Yeah, definitely we see a lot of cooperation going on.
Fantastic. Maybe I'll go next to Dr. Trowell. James, any new collaborative opportunities for your lab?
Well, I mean, I'm lucky because I'm an infectious disease modeler. I'm probably the only person in one of a handful of people in the entire country who actually has more opportunities as a consequence of the pandemic than most others. I mean, I don't like being stuck at home and in stage 4 lockdown, but I guess it has actually opened up some opportunities for me. But I'm in an incredibly tiny minority. I mean, across the whole of society, the pandemic has obviously had a terrible effect on a lot of people because they died or lost loved ones to begin with, and then the lockdown effects, I think, have had an effect of atomizing and fragmenting our society as a whole. So I think there's no question that it's been a very negative experience for the whole world, and there's a lot of people out there suffering a lot. What remains to be seen, I suppose, is as we recover, whether there will be I think we'll be living in a different world. I don't know how it will be different exactly, but I hold out some hope that as we go through that process of recovery and everybody's had a chance to sort of reflect on what's important in life, that we'll build a society that's a bit more cohesive and stronger in the coming years. But that certainly remains to be seen at this stage.
That's a great comment, James, on that. Dr. Ibrahim?
Yes. So a couple of collaborations I would encourage. We tend to live in our little bubbles or in our little intellectual cocoons by profession, but I have interest in multiple fields, so I see tremendous correlation. I think that there is a tremendous opportunity for collaboration between the biological sciences and the people who are doing the modeling work in this field with the cybersecurity community that is trying to protect critical systems like industrial control systems from viruses. And I've written actually articles on this about how some of those best practices could also be applied in protecting populations from pandemics. Then the other collaboration that we sorely need is with social scientists who are talking about designing new urban systems for the future, about what a centralized infrastructure does in creating vulnerabilities in a pandemic, and how we need to build, smart communities as opposed to large smart cities where you're completely autonomous and you are generating employment and you're living in small clusters so that if there is a pandemic, they can go into lockdown from the other clusters and remain safe and continue to operate and not have to have these lockdowns across all the communities. So I think the cybersecurity community and the social scientist collaboration with the life sciences is sorely needed.
That sounds great, and it's so multidisciplinary, Dr. Ibrahim, what you just referred to, as well as, of course, James, your comments around society coming together, I think, and humanity coming together. I think those are very valid points. Dr. Kai, you also mentioned about, China's challenges with a big population. So, look, at the end of this live Q&A, we've obviously just gone a little bit over time, but I really want to thank each of the speakers that has joined us. In fact, Dr. Ibrahim has actually joined us from US. It's way past his bedtime. It's over 1:30 a.m. right now over there. So I really want to have a special thank you to Dr. Ibrahim for joining us live. And that concludes our live Q&A for this first day of our conference. Please join us tomorrow morning, Singapore time, 10 a.m., for the second day of the conference, Paradigm Shift in Infectious Diseases, lessons from a pandemic. And we look forward to seeing you again engaged. Our third theme is diagnosis and innovation during a pandemic, followed by viral and therapeutics theme. So with that in mind, I'd like to again thank all the speakers. And if there's any final comments from any of the speakers, please go ahead.
I'd just like to say thank you very much for having us. And, some things are worth staying up all night for. And this is definitely worth it when I see 231 people in the audience listening to me. And it's just a great honor. And to hear the views of James and Dr. Kai, it was a true pleasure and honor for me. Thank you.
For me too. Thank you so much for having us.
Yeah,
thank you
for organizing this event. Yeah.
Thank you very much, gentlemen. Thank you very much. All right, that concludes us, and have a great evening, everyone.
Thank you.
Bye-bye.
Bye.
Bye.